I'm Dr. Fiona Lovely, and this is the Not Your Mother's Menopause podcast. I'm taking the taboos of menopause and peri-menopause and bringing light to the dark. No bullshit, no shame. It's time for us to gain a new paradigm in female health, out with the old and in with the new, and I'm bringing fresh perspectives from someone in the arena. I've been practicing women's health for nearly 20 years, and I'm spilling the tea on what it means to live at midlife, knowing that the best is yet to come. I'm sharing my Gen X approach to living through this transition. Sassy, a bit sweary, and always honest. Tactical tips and instantly usable information is my aim. I hope to make you laugh and that you learn something new that helps you embrace the change. Together, we bring power to the peri. Onward to the podcast. You're tuned into the Not Your Mother's Menopause podcast. I'm Dr. Fiona Lovely. Today, I've got a conversation for you that millions of women have been waiting to hear, probably for a really long time. It's a conversation about the parts of our bodies that our doctors glossed over, dismissed, or we simply never learned enough about. These are the symptoms we were told to push through: the bladder pain, the burning, the pressure, the urgency, the experiences that quietly erode the quality of our lives while the medical system hands out another round of antibiotics and calls it a day. I know I've experienced this myself, so this is a personal conversation. We're talking about bladder health. We're talking about pelvic health, urinary health, and we're talking about sexual health today too. Because all of these systems are connected, all of them are affected by the hormonal shifts of perimenopause and menopause, and all of them deserve to be talked about clearly, clinically, and without shame. In this episode, I sat down with two remarkable women who have dedicated their careers to doing exactly that. Dr. Christine Vaccaro, urogynecologist and reconstructive pelvic surgeon, and Heather Florio, CEO and pelvic, bladder, and urinary innovator and researcher. Man, this is a big conversation. And we talk about interstitial cystitis, a condition affecting up to 12 million people that's still routinely being misdiagnosed as recurrent UTIs. We talk about what declining estrogen actually does to the bladder and the sexual anatomy and the vagina. The vaginal microbiome we talk about and the pelvic floor, all part of what we now understand as the genitourinary syndrome of menopause, or the GSM. This is the kind of conversation I love, and I wish I could send back in time to every woman who has ever been told to just live with it. Let me introduce you to my guests. Heather Florio is the CEO of Desert Harvest and one of the most passionate and persistent voices in pelvic, bladder, and urinary health. What makes Heather extraordinary is that this isn't just her career, it's her story. She has lived with interstitial cystitis herself, and that lived experience has fueled more than 30 years of research-driven innovation in natural therapeutics. Under her leadership, Desert Harvest has grown more than 15-fold, not by chasing trends, but by investing in real science and expanding access to care for women around the world. Heather is the co-author of The Musculoskeletal Mystery, a conference speaker, and the writer behind Bella Magazine's Dear Sexpert column. She was one of the only CEOs invited to the FDA's Black Box Warning Summit on hormonal health advocacy, and she showed up and pushed hard. She's been featured in Forbes and Business Insider, named to Authority Magazine's top women in wellness lists, and is currently collaborating with Oxford University on a multi-strain UTI prevention study. She also leads educational programs in underserved communities, including Peru, Turkey, and the Gambia, because she believes that every woman everywhere deserves access to this information. My second guest is Dr. Christine Vaccaro. Her own origin story alone will stop you in your tracks. She's a double board certified fellowship trained urogynecologist and reconstructive pelvic surgeon with advanced training in sexual medicine, including the full spectrum of genitourinary syndrome of menopause and its impact on bladder, pelvic, and sexual health. She has published research on interstitial cystitis, pelvic floor disorders, and clitoral anatomy, an area that remains remarkably understudied given how central it is to women's sexual health and well-being. She is an active member of both the American Urogynecologist Society and the Society of Gynecologic Surgeons, contributing to committees focused on advancing education and research. But before all that, Dr. Vaccaro graduated from the United States Military Academy at West Point. She earned her Doctor of Osteopathic Medicine, completed her OBGYN residency, and went on to serve as Fellowship Program Director and Service Chief of Urogynecology and Reconstructive Pelvic Surgery. She also retired from the United States Army with the rank of colonel. A colonel who turned her full attention to pelvic floors and making sure women are no longer left behind by the medical system. She works in clinic with Dr. Rachel Rubin, who many of you know as one of the most important voices bringing pelvic and sexual health education to the masses, and that connection is very much felt in the conversation we had. This episode is a gift, and it's for the woman who has been told her symptoms are in her head, for the woman who has been handed antibiotics for the 5th or 25th time with no real answers, for the woman who didn't know that's what she was experiencing, has a name, interstitial cystitis, or the genitourinary syndrome of menopause, and that there's help available. Sister, I got you for this one. Let's get into it. I think you're going to love it as much as I love being a part of it. Thanks for listening. Menopause skin. Nobody's favorite part of the transition at midlife we call peri-menopause and menopause. If you're noticing fine lines, wrinkles, or sagging skin, maybe more texture during your menopause, I have some really exciting news for you. Menopause can deplete your skin's collagen, speeding up the aging. But here's the news. Vitale Skincare has built its entire line on the power of GHK-Cu copper peptides, a proven ingredient that signals your skin's stem cells to produce new and healthy collagen. My personal favorite, Vitale's Restorative Skin Cell Serum. I love how it rejuvenates and restores my skin from within, revealing a firmer, more radiant glow. Want to experience this transformation for yourself? Head to vitaleskincare.com and use the code LOVELY at checkout for 20% off. That's vitaleskincare.com, VITALI skin, SKINCARE.com, code LOVELY. Because with Vitale, youthful, vibrant skin is just a step away at any age. If your energy levels feel low and you're experiencing digestive issues like gas and bloating, even when eating healthy, nutritious foods, imagine how you might feel during the indulgence of the holiday season. Adding a high-quality enzyme supplement to your routine could make a big difference. I personally recommend Masszymes by Bioptimizers. It's a best-in-class supplement loaded with full-spectrum enzymes for digesting proteins, starches, sugars, fibers, and fats. After you start taking Masszymes, you may notice that you no longer feel bloated after meals and that your belly feels flatter. These powerful enzymes boost your energy by increasing metabolism of your food for fuel. And by improving digestion, your body has more resources to allocate for mental and cognitive function. I can definitely vouch for these enzymes. I take them myself, and they are powerful. For the entire month of November, Bioptimizers, the makers of Masszymes, are having a Black Friday sale, their best sale of the year. All month long, you'll get discounts with my unique code, plus access to up to $100 in free gifts with purchase. You can only get this exclusive deal through my link, special for the audience of the Not Your Mother's Menopause podcast. You won't find this on Amazon or even on the company website. Go to bioptimizers.com/lovely and use code LOVELY to get your discount and free gifts today. All Bioptimizer supplements are best in class. If you don't agree, you can get a full refund for up to 1 year after your purchase, no questions asked. Again, the link to go to right now for this exclusive deal is bioptimizers.com/lovely using the code lovely. Links in the show notes. This is the Not Your Mother's Menopause podcast. I'm Dr. Fiona Lovely, and today we're pulling back the curtain on the taboo subjects of menopause, as we so often do on the show. I've got friends in women's sexual health on the screen with me today, here to educate us on pelvic health, urinary and bladder health, sexual medicine, and whatever other goodies come up while we have a conversation. Dr. Christine Vaccaro and Heather Florio, welcome to the show.
Thank you for having us, Fiona.
Yes, it's so fun. Okay. So we've got to address the elephant in the room, which is that Dr. Vaccaro, you work with Dr. Rachel Rubin, who everybody is talking about in the menopause space right now. So we're just going to say how cool that is. And please, on my behalf and on behalf of my listeners, thank her for dispensing the beautiful information that she has.
Absolutely. I love her content as well. I'm a consumer as well. Yeah.
She's fantastic. I loved seeing her take some of the big podcasters right to the end of, okay, well, here's what you haven't learned in your medical education. Let me show you what you haven't learned about how similar female and male anatomy is, and how it all comes from the female anatomy, essentially, right?
Absolutely. The default is female. So
yes, the XX chromosome. Okay, Christine, actually, you are an expert in clitoral anatomy. Is that correct?
I am. I'm actually one of the OG clitorologists, and I actually wear a necklace. One of a kind. Yep.
Gorgeous.
So I started studying the clitoris back in like 2010.
Isn't that fantastic? Well, I find it shocking that was, we didn't study the anatomy of the female pleasure anatomy in particular. Can you talk a little bit about that?
Yeah, so I guess it'd be helpful to share a story, like how I kind of like my origin story, so to speak. So I was in my urogynecology fellowship and saw a patient that was experiencing clitoral pain. And I was so excited because this was some area that I had never had no patients ever come in with this complaint. So I was like, oh, this is gonna be great. I can't wait to learn from my senior urogyn attending on all this, drink from the fire hose of wisdom that's gonna happen here, right? So I present my case and he stares back at me blankly like, we don't have any tools, we don't have any guidelines, we don't have any information on clitoral pain. So very sadly, this very vulnerable patient left without therapy. And I was like, he must have like missed some huge content and some major block of instruction. So I go to PubMed and type in clitoral pain, and there were 0 hits. And I was like, maybe that's too specific. I'll just type in the word clitoris. And there was like literally one publication published in 2005 by an Australian urologist and a US urogynecologist. And that was the first detailed publication of clitoral anatomy. So of course, what does any good doctor do when we don't have enough research? I became the researcher and started studying it in my fellowship. And it's just become a passion project of mine to have some genital equity, right, in between the genders. So that's something that I'm very passionate about educating as well.
Did you just say that's actually how equity? Oh my goodness.
Yes.
Wow.
This is actually how Dr. Rubin and I sort of met as well, because everyone knew this was my passion project, and she had an article in the New York Times about, everyone, half the world has a clitoris, why don't doctors study it? And everyone forwarded me this article, and I was like, oh my God, I have to know this amazing person. So we connected, and lo and behold, we were in the same city the whole time. And when I retired from Walter Reed, that's how I joined her practice. So it's weird how you can have parallel sort of passion projects and then just have the right thing bring you together. So.
Oh, absolutely. We find each other certainly in those times. Okay, Heather, you also have a research connection, correct?
Yeah, so actually that's how I came to Dr. Rubin. And we connected was through interstitial cystitis. So we actually have been doing 33 years of clinical research on interstitial cystitis, which is a bladder disorder that feels like a constant UTI that never goes away is the best way to explain it. And it's debilitating, affects probably about 75% women and then about 25% men. We estimate 8 to 12 million men and women in the United States alone have this condition. And so we're dealing with this specifically. And then I met Dr. Rubin, and she really kind of helped us kind of further the idea of hormones as it related to interstitial cystitis and kind of helping us to phenotype out the different conditions, because it is really much a diagnosis of exclusion here in the United States. And as a result, it leaves a huge burden, especially for women, because a lot of the times they're misdiagnosed and they have other conditions or other comorbidities that are leading them to seek and think that they have interstitial cystitis, because as women we have so much going on down there, and we're looking for guidance. And so that is kind of where my background and how I led to Dr. Rubin and thus Dr. Vaccaro. So
Yes. Yes, I love it. Okay. Let's talk about IC, because this is one of those things that, again, doesn't get talked about enough. It's part of the genitourinary syndrome of menopause. Is that correct?
it can be. Yeah, I'll let
Yes.
Dr. Vaccaro kind of go
Well,
into that.
what's funny, Fiona, is when Heather was speaking, this is something I've thought a lot about lately, which is, and again, this isn't well described in literature, but we know very well about the genitourinary syndrome of menopause. We know very well now about the genitourinary syndrome of lactation, which are both hypoestrogenic states, meaning we're just focused on the one hormone, estrogen, and how it affects the genitourinary system. But what we haven't, I think, really clearly delved into is how both estrogen and testosterone are so important for the genitourinary system. And oftentimes, and Heather, I'm sure will feel this way as well, if you give back both hormones to the genitals, how often the bladder feels so much better. And a lot of the IC, or now sometimes termed female painful bladder syndrome, symptoms go away. So is this just a more severe form of undertreated hormonal deficiencies of the genitourinary system that is manifesting with severe urgency and severe pressure when the bladder is full and feels better when the bladder is empty? Is it just a more severe form of a hormonal dysfunction? And I now that I've started to treat patients more with both androgens and estrogens to the genitals, and I'm really seeing how much this really oftentimes phenotypically can be a hormonal problem of the genitals and the
Wow.
urinary system.
The things we didn't know until we knew it, right? And
Yeah.
I think about, I do believe it's Dr. Rubin that tells the story of her mother with the bladder symptoms in the hospital, right? My
Mhm.
mother had the very same thing. When her dementia would get, she would have a flare, and that's not quite the right word, but when her symptoms would be really active, we knew she had a bladder infection that was going. So, let's break this all down. Somebody please educate us. What's the difference between a bladder infection, a UTI, and interstitial cystitis?
Yeah, so a little bit, one of the biggest things is, especially for interstitial cystitis patients, and there's going to be a lot of research that's going to be released here soon. We actually have the American Urologic Association meeting coming up in May in DC. And one of the things that researchers have been doing, I was part of the consortium that came together with the ESSIC committee, which is a worldwide interstitial cystitis board. And last year we were looking at phenotyping, like we had mentioned. And interstitial cystitis really is one of those things in which there is no bacteria present. This isn't related to uropathogens. They're theorizing that potentially the genitourinary syndrome of menopause is less of a condition of interstitial cystitis and a separate condition where if you're not on HRT, that bladder lining, the gag layer, the urothelial cell layer in the bladder begins to degrade over time during menopause and lead to these symptoms as a result of not having the necessary hormones. But what they're theorizing now is interstitial cystitis is a completely separate condition. Whether there's been theories of of it being an autoimmune disorder. And one of the things that we don't do here in the United States that's done in the rest of the world is we actually put a scope up the urethra to look into the bladder. And you can only, in the rest of the world, be diagnosed via cystoscopy because for them, interstitial cystitis is truly true bladder wall impact, ulcerated, inflamed, red bladder. And that is truly interstitial cystitis. And then we have this entire other group where it's kind of falling under the umbrella of bladder pain syndrome. And we're slowly beginning to create research to phenotype out these conditions. In fact, at UCLA, we did a study done by Dr. Lenore Ackerman, where she actually used AI machine learning because we have gotten nowhere because research is so muddied in the world of interstitial cystitis because of it being a diagnosis of exclusion in the United States. It's hard to get to the true interstitial cystitis patients. So we don't understand etiology. We don't understand phenotyping. So she took an AI model instead, dumped all 600 and something urology patients that were suspected of interstitial cystitis at UCLA into this machine learning program with a series of questionnaires that all of the patients had answered, and found that there were three distinct categories. There was true bladder-centric pain, that all their pain was coming from their bladder, and these were that interstitial cystitis group. And then you had two other groups that were more like non-specific. So that would be like your neuralgia pain, maybe your hormonal related, menopause related pain. And then you had this group that had just completely myofascial pelvic floor dysfunction, and 88% resolved with pelvic floor physical therapy. So it was really important for us to figure that out because then it helps us to create two distinct different categories in which we really have interstitial cystitis and bladder pain syndrome as two completely different conditions. And I think that's where you're going to see this going forward. And I think those that are hormonal, the question becomes, and I don't think we've really done the research, and I hope that we get to that point, is where we're looking at those women that are menopausal, that are experiencing interstitial cystitis like symptoms and discomfort and disability, are finding that the question becomes, when you get postmenopausal and you're at that point and you start getting into HRT, what happens to that bladder lining? We really need to investigate and really see, and actually see, like we're doing with our aloe vera, our SSAV here. It's undergoing FDA drug trials right now. We're watching how it interacts with the urothelial cell layer of the bladder, what it's doing, and exactly how it's functioning. It'd be really interesting to know the same thing with HRT in a sense, to understand more of what happens to that lining. Can that lining start to rebuild itself with HRT? And these are all questions that we kind of have unanswered at this point. Long-winded answer, I guess.
No, but I mean, there's so much. I'm sorry, Dr. Vaccaro, if you had something to share there.
Well, I just wanted to just say two additional things. One, just like Heather was saying, to diagnose IC or bladder pain syndrome, you have to exclude UTIs, meaning we have to make sure, right? Because a lot of symptoms do overlap, specifically the urgency and then the nighttime urination. Those symptoms generally are true for UTIs as well. However, I often see in my patient population, right, that sometimes they have both, right? Two things can be true. You can have recurrent UTIs and you can have IC and bladder pain syndrome. So sometimes patients really get just treated for one thing, which is most commonly recurrent UTIs. And the diagnosis of IC takes years to decades to figure out, because oftentimes women get treated with antibiotics and often with pyridium or azo, if you know azopyridine. And that is a numbing agent, a pain agent for the bladder. So these bladder-centric patients, they get a treatment, right, a therapy, antibiotics, and something that numbs their bladder, and they feel better. So they think, I must have a UTI. This must be what I have. And they keep going down these flares, which they think are UTIs, over and over and over and over again. And the diagnosis gets missed for years to decades. So I always want to just say that, because a lot of times women are thinking they have recurrent UTIs, but they also could have IC that's just been misdiagnosed. Oftentimes, a standard urine culture also misses some bacteria, so that's also something that's possible. So there still can be bacteria even with a urine culture that shows that there isn't, because you have to have all the right conditions. A lot of times now we're doing more specific PCR, meaning looking for the genetic material instead of what can grow in a petri dish sort of idea. So we're getting better with how we find infections. But I do want to highlight there has been some limited data showing that there's different microbiome, microflora in the bladder patients that have IC versus those that don't. So there is that. There is some sort of hormonal changes going on that favor either lactobacillus, which is the healthy bacteria that lives in the vagina, can also colonize the bladder in healthy patients, versus patients that have IC that generally have less lactobacilli. So that research is still sort of ongoing. But I do agree strongly with Heather, right? We have these bladder focused patients that also remember the vulvar vestibule, which we haven't talked about yet, is urinary type tissue, which is right at the vaginal opening where a lot of patients feel urgency. So again, this area can also be involved in the symptomatology of urgent. There we go. I love it. Yes, right there, baby. And that area also can feel urgency, right? The innervation is the same between the vulvar vestibule and the urethra and bladder. So this sense of urgency can come from the vulvar vestibule, the urethra, the bladder, this sort of urinary tract area focus versus, just like Fiona said, right? Could this be a spine issue? Could this be a nerve issue? Could this be some other like endometriosis that is attached to the bladder that's causing pelvic pain, right? There's so many other etiologies, which is why it's so important to do a really, really good history and also a really good pelvic exam. I start with like a Q-tip test to test the vestibule. I feel the urethra, I feel the bladder. Then I feel the pelvic floor muscles, right? Which can also be a source of urgency felt because of hypertonic pelvic floor muscles. And then lastly, I feel the more higher up structures, cervix, uterus, ovaries, to see if there's any sort of potentially endometrious or deep pelvic pain. But it is very complex. It takes a skilled clinician to kind of peel the layers back to really figure out what is going on.
Yeah, and I imagine, like, as you're describing your exam, I've never had an exam like that in 52 years. So, how many women have? And I'm just wondering how, when you were doing your training as a urogynecologist, how much were you actually exposed to that level of digging in and being able to see, looking at the different structures, trying to discern what is actually going on versus what is the standard of care?
Yeah, that's a great point. I think the standard of care is not what I got. I was actually very lucky. I in my fellowship had another female faculty that was very involved with female pelvic pain. She helped me a lot to help break this down and do a very systematic exam, because oftentimes as a gynecologist, most are taught just to do a bimanual exam, which is examining the cervix, uterus, and ovaries. And for any woman, whether it's vestibulodynia or it's bladder pain or some other deeper structures, if you reach your hands in the vagina and just start mashing around and ask, does it hurt? It's not very helpful, right?
No.
Because it could be the vestibule, could be in pain. It could be the bladder you're mashing on, it could be an ovary, it could be the cervix, right? That's a very non-specific way of doing a pelvic exam. I can't tell you how many patients have had a hysterectomy with both ovaries removed that actually the problem, the source was vestibulect, like the vestibule.
Wow.
And that's certainly not going to get treated with taking out their uterus and cervix and ovaries. So doing a really good systematic evaluation, starting from the outside and slowly working your way inside, is something that I advocate for, as well as Tight Lip, which is an organization, a grassroots organization that also teaches this and is trying to add this to OBGYN curriculum nationwide.
You called it tight lip, is that right?
Tight-lipped.
Lipped. Okay, very good. Of course. I love all these little plays on words. I truly, I mean, I've been part of the female health world now for 25 years, and what I'm seeing for a lot of that time, hormones were verboten. We were not touching them. We had the Women's Health Initiative and all of this business. As you guys know, the residue of that, unfortunately, still informs the majority of practice, which is just so incredibly unfortunate, especially when we're talking about family medicine practitioners who are doing most of the prescribing for HRT for women. That's certainly true in Canada, and it sounds like it's still the truth in the United States as well. But what I'm seeing and very hopeful about is the fact that women are now coming together to take care of business for women. Like, we're not relying on the powers that be to take care of us, to get shit done. Like, it's literally us coming together and saying, okay, how can we figure this out? And we've all got personal stories, whether it was
Mhm.
our own experience. I'm a repeat UTI gal. Boy, am I learning about this stuff now. The amount of antibiotics I've had in my lifetime, and then I get a prescription for topical estrogen and haven't had a single UTI since. I
Yay,
know,
Fiona!
but
Success
Yay.
story. I love these.
exactly. But this is the thing, like, why am
But
I the
why did it
guy?
take so long? Yeah.
Exactly.
Yeah.
Why am I the guy that had to go to my own GP and say, hey, listen, I've got a nurse practitioner who's just prescribed me this. So thank you for all those antibiotics over the years. But actually, this is what the problem was. And of course, by that point, my mother was already declining from dementia. She was also a repeat UTI person. So again, I ask the question, like, how many, it's the misdiagnosis thing. Like we're just left that completely out of women's health, this urinary and bladder health. It matters.
Yeah.
It
Mhm.
matters.
It does. I
Anyways,
mean, cyclically, when we treat over, and that leads to so much. I just did an interview with Physicians Weekly because we were talking about the overusage of antibiotics in this cyclical environment where we go in the doctor's office, they do a dipstick test, they say, "Oh, yep, you're positive." They send you, but then when it comes back from culture, 3 days later, it's, oh no, you're all good to go. You don't need anything. But in this time, you've just started taking antibiotics. So we've created this
anyways, yeah,
very unhealthy cyclical environment in which women especially are suffering because we're destroying our gut biomes, our bladder biomes, and our vaginal microbiomes. Like
yeah.
we need better education, better advice. And it's like Dr. Vaccaro, like we were in that room at the FDA, sitting there, 41 women. That room was packed, and the
It was.
energy in there and the enthusiasm. And these are all women going out, educating, making a difference, and trying to change the norm. And it's a road ahead, but this path forward seems bright. So
I
I love
agree.
it. And I was watching. So thank you for being in the room. I know there was lots of us watching from around the world. Now, one of the things that I do with my work is I've taken what I have learned as a non-prescriber, and now I train other women who are non-prescribers to be menopause coaches. I call them menopause doulas, and
Mhm.
sharing the link to the FDA. And that I just was starting to teach a new class when you guys were up to that. And we had a beautiful discussion about it because things are really changing. It's not hiding anymore. We're actually talking about it. We're getting in. And again, it's us wise women that are stepping in saying,
mhm.
enough. We're not going to suffer anymore. We are smart enough. We have the resources. Let's get this stuff done for sure.
Yeah, it's like the clinicians. There's ways in which you can go around the systems. That's the great thing. These women are creating ways when you don't have amazing, compassionate, educated doctors like Dr. Vaccaro, treating you, and you have what is available to you in your rural community. There are amazing platforms like My Alloy and MIDI Health and things like that, where you can go onto these platforms made by women for women, in which you can get truly menopause trained doctors and get the education and the HRT that you need without the dismissal part or the
Mhm.
lack of understanding. So,
And Fiona, I love this idea of a menopause doula or just a friend, right? Sometimes women just need a friend holding their hand and advocating for them, because sometimes as a woman, the power dynamic is different, right? When you go into a physician's office or a clinician's office, you feel sometimes women don't feel like they can speak up, or if the conversation's not going great. So having someone there to be like, okay, but did you hear this? And did you hear this? And what about
Yep.
this? And we heard this. And, like it's sometimes good to have, if it's not your partner, but having someone there to advocate for you. So I love this idea. So
Yeah,
great.
it's fantastic, right? Thank you. One of my students is actually doing a fireside chat with the LA clinic sometime in the
mhm.
next few weeks, she said. So I don't have any more details than that, but I'm also very excited about it because, and I'm sure you guys have felt this too. I mean, the amount of women that have said to me over the years, why don't my doctors know this? Why is it so hard to get help? And of course, I'm over here going, well, it's just me. I wish I could do more, which is why I started the podcast 11 years ago. I had no idea that it was going to be a phenomenon like it has been, but which is cool. Again, the goddess speaks and we step up. That's what I say. But how do we take the coaching, what we learned, and share it with others? I think, again, this is what happens when women take care of business for ourselves.
It's true. So I feel obligated to share
Please.
this crazy story. So, you know, after graduating from college, I did 12 additional years of training. Okay. And I was given I'm talking minimal training on peri-menopause and menopause. And I am a quality of life subspecialty gynecologist that literally my whole job is quality of life, right? I do mostly pelvic floor disorders. And yes, vaginal estrogen's always been a very strong tool in my toolkit, but full body systemic hormones, I didn't get any training, zero. So Fiona, when I myself, right, I'm a 50-year-old woman, can admit that I am in the throes of perimenopause, right?
Mm-hmm.
I didn't have any training on how to just take care of myself. Like I had to, as an educator, train myself, go seek extra knowledge, become a menopause certified practitioner. Like I had to teach myself because the medical system didn't teach me. And if I'm not getting taught as a subspecialty,
Who is?
quality of life gynecologist, no one, right? No one's getting taught this thing. So we have, in the last 20 years, had just like a desert of clinicians getting trained. And it's crazy when 100% of women who reach midlife are going to have symptoms.
Yeah.
And we don't have doctors trained. It's horrifying, which is why, as a pelvic floor specialist, I've decided to really switch gears and do more of this work because I'm angry, right? And I want to advocate for women so that we don't have to suffer. No one should have to suffer through any of these symptoms. So that's why I do a lot of advocacy work.
And thank you for doing that. And Heather, I know you do it too. And I just want to say that anger piece comes up a whole lot for me. In fact, I just wrote a blog about it for my newsletter this morning about when I hear the treatments that are making a difference for women now, I think about my mother, I think about my grandmothers, and I think, what if they had had the option? It makes me just mad as hell to think about it. But I think in a way we can let that anger drive us forward, like we
100%.
Yes.
Use it for good.
Yeah.
Righteous anger. Here we go. We got some pissed off ladies that have, by the way, a patient crocheted this for me. Isn't this great?
I love it. It's beautiful.
That's wonderful.
She even got a urethra in there.
I love it. So good.
Anyways, okay. Heather, I want to come back to you. Can you, for the ladies that are listening, can you give us an idea of what interstitial cystitis feels like?
So the hallmark symptoms are frequency, pain, burning, nocturia, so that's waking up at night, having to go to the bathroom. Those are kind of the four really hallmark symptoms, which, as Dr. Vaccaro alluded to, overlap with a lot of other conditions. So it can make it very difficult in that diagnosis. So, but you can imagine, I'm sure most women listening to this conversation have had a UTI, and that's how I best always explain it, because imagine that UTI, but imagine it much worse and never going away. And that's what most of these women deal with. And we see that diagnosis 10 years, 30 years. We've been doing this with interstitial cystitis patients since 1993. And if we think it's a desert now, back then, where there's tumbleweeds everywhere.
Crickets.
Yeah, crickets. Like even now, we can go to different events and stuff like that and still be very much dismissed that, oh, that's all in their head. There's nothing wrong with them. They're perfectly fine. And so it's still a hard fought fight that we are still fighting to get, back then in the 90s, nobody recognized it. It was the amazing field of urogynecology being born that really started to give, especially predominantly a woman-led disease, that or condition that specifically, urogynecology gave them a place, a voice, somewhere where they could feel understood, and not completely dismissed, because unfortunately most of our urologists are focused on, when I go to AUA, they're mostly going to be focused on kidneys and bladder cancer, and not the chronic pain conditions, not the ones that need that, that compassion, that understanding, that full understanding of who they are from head to toe. And understanding, there aren't many people, like Dr. Vaccaro mentioned, that can sit there and feel the musculature and understand. I do labs all over the world, in remote areas of the world, teaching these clinicians how to understand their musculature and doing labs. Like I've been locked in a hotel room in Turkey because with guards, because nobody could go, and we had to stand there, but behind the doors, these clinicians are, and they're PTs, they're pelvic PTs, but they everything they'd learned was from the outside. Nothing that they had learned was from the inside. So many clinicians don't understand when they're feeling in there, to understand what they're feeling, what it feels like, to understand if they're feeling like endometrial stomas, things like that. I heard one doctor, the last thing, interestingly enough, in Europe, I was at EAU just in March. And interestingly enough, what they're doing is actually, besides diagnosis via cystoscopy, they're also doing exploratory. Certainly, yeah. So literally
Wow.
camera and looking, because they can't distinguish between interstitial cystitis and endometriosis of the bladder, because most of the time the stomas, the endometrial tissue, ends up on the outside of the bladder, and you're sitting here thinking, oh yeah, all the pain's coming from my bladder, this is where it's at, I completely understand. And they're finding and being able to exclude subtypes out, because they're finding, oh no, you just have endometriosis all over the outside of your bladder.
And I do think, and I love that you brought that up, I do think these conditions overlap a lot, right? Just like we talked about before, the phenotyping, right? There can be a problem with the gag layer, which is the glycosaminoglycan layer, which is inside the bladder. But there can also be, which is more bladder centric, there can also be very inflammatory endometrial implants on the outside of the bladder. And then there can be nerve problems that are coming from somewhere, anywhere from the bladder up to the spine, up to the brain, right? So there's such a large constellation of where is my pain and urgency that I feel is coming from my bladder, but it could be coming from anywhere along those
Wow.
pathways. So
Wow.
it can be really complicated. And Fiona, if you don't mind, I'd like to just run through really quickly, just like self-help things for patients that do have bladder pain / interstitial cystitis, because I think sometimes it's nice just to be like, what can I do
Yes,
from very
please.
simple things, right? So I often, for first-time patients, I run through um, bladder irritants, which for some patients, they already know. They come to me like, I can't eat this, I can't eat that, right? So just real quickly, one of the most irritating substances are anything that is acidic. So if you think about, if you're a bladder-centric patient and you have a problem with the slippery coating of the bladder, which is the gag layer, think of like a slick layer that protects the urine waste, the liquid waste from our bladder muscle, right? There's a slippery coating that should be there. And if that's disrupted and you eat acidic things, it's like pouring acid onto the wound, right? It makes things worse, makes things really flare up. So trying to avoid acidic things, which is coffee, which is very acidic, which people love, but it's really acidic. There are low acid options that I sometimes tell people to try. Spicy foods, right? So anything real spicy usually causes more of a flare. Anything that has caffeine in it generally makes the bladder fill fast. It might not be caffeine as the irritant itself, but just the fact that it's a diuretic, it makes the bladder fill really fast, which means the symptoms come back pretty quickly. And then other acidic foods, anything citrus acid, lemon, lime, grapefruit, pretty acidic, and then also cranberry. And this gets really tricky because people are often like, oh, but cranberry is helpful for my bladder, because it's often promoted as a health aid for the bladder, right? So these
Yes.
patients that think they have recurrent UTIs that might actually be bladder pain are sucking down cranberry juice, right? But that's really tart. If anyone's had cranberry juice, they know you put it in your mouth and, it's like really tart, right? That's the acidity. So trying to cut back on irritants and journaling a little bit to find out what those triggers are. So that's the first layer. And then if it's like, but I want to have a coffee, I want to have this, I want to have that, you can do a neutralizer. So pre-leaf is like a neutralizer like Tums, right? It's an antacid to help
We have
calm
it
that
too. It's
acidity.
calcium glycerophosphate is what it
Yeah.
is. Yeah.
So you can do the pre-leaf, which is sort of marketed for the bladder, or you can
Right.
just do Tums. It's basically an antacid to neutralize the acidity so that the effects aren't as bothersome to the bladder. So those are kind of just like simple things, as well as over-the-counter azo or pyridium, which is phenazopyridine. So if you're looking at azo products, they're not all the same. Make sure they do have the name of the medication, phenazopyridine, which again is kind of like, I make the analogy of it's like, like Tylenol for headache, right? It treats the symptom of discomfort and pain that can be bladder centric, but it doesn't fix the problem, right? It's not going to heal the lining of the bladder. But we do have some treatments for patients that have bladder centric issues, and those are bladder installations. That's where we put therapeutic medication into the bladder to help heal those cracks. So there's two medications that really help heal those cracks. One is heparin, which is something that we can put into the bladder, and the other is DMSO. It smells like garlic. It's really expensive. So most people favor heparin. But again, you have to have a provider that knows the right cocktail to be able to do those therapeutic solutions. And then we have bladder Botox, which is another great emerging therapy for bladder pain patients because it treats not only the muscle spasm of the bladder, but also disrupts the pain signaling in the bladder. So it kind of treats two different mechanisms of potential bladder pain. And then another therapy I really like if I've done all the bladder work and nothing's working. And obviously, if she's also hormonally replete, we've already established hormones can be really important here as well. If all those things have happened and still she's not getting better, that's where I use sacral neuromodulation as another tool to help with the neuro component that could be contributing to the problem. So I just wanted to run through that just so people know that they don't have to just, deal with the pain. There's lots in the algorithm that can be done. And I would be always remiss to say working with a good pelvic floor PT, because generally when patients have a lot of pain long term, the muscles of the pelvic floor are just really, really tight because they've been suffering for so long. And treating the muscles to get them to also relax is also critically important.
Let's talk about sleep for a moment. Because if you're navigating peri-menopause or menopause, you know that a truly restful night can feel like it belongs to another lifetime. The night sweats, the restless hours, the 3 a.m. wake-ups that leave you exhausted by the time you're supposed to get out of bed. This is exactly why I want to tell you about Cozy Earth. Their bamboo sheets and pajama sets are made from viscose from bamboo, temperature regulating, and moisture wicking, designed to sleep several degrees cooler than cotton, so your body can actually rest even when your hormones have other ideas. This isn't about fixing menopause, it's supporting your body through it with comfort that adapts to the season you're in. And Cozy Earth stands behind their products with a 100-night sleep trial and a 10-year warranty, because quality, comfort shouldn't come with an expiration date. Head to cozyearth.com and use code LOVELY for 20% off. And be sure to tell them I sent you in their survey. Because the woman who holds it all together deserves to be held in comfort too. Thanks, Cozy Earth. I want to just say here for anyone listening, I can hear the women in my community going, no, my muscles aren't tight. I've got a loose pelvic floor. Oh, this one just gets so, okay, listen, guys. So, and this is what I tell my doula scholars as well, is that your pelvic floor physio in your network is probably going to be your most referred to person other than whoever the prescriber is, whether it's a nurse practitioner or family medicine practitioner, or actually, it's terrible to say, but the gynecologists are not even the right choice for HRT around here, which is amazing to me. How did that happen? We can talk about that in a minute. But anyways, for those listening, the chances of you having, first of all, the laxity of the pelvic floor situation, we can trace that back to the paternalistic nature of our society, which says everything's around the penis. And a woman does not know if her vagina is loose, for God's sakes. That's not even a thing. So please, Dr. Vaccaro, help us out. Help me out. What do you have to say about this?
Yes. So I do think there's two things here. One is there is a syndrome that women feel a widened introitus, again, typically after multiple vaginal births, right? Where the opening of the vagina does feel larger and things want to fall out. There we go, visual, right? Which is the condition of pelvic organ prolapse. Sometimes things aren't actually protruding through the opening, but the opening itself just feels widened. Women often experience symptoms of air trapping, where when they open their legs a little bit, air sucks in, right? And then it comes out later, which is very bothersome because you can't really control that. So there are some symptoms of looseness that women are bothered by. Now, sexual activity, again, the vagina is not generally, for most women, the most sexually pleasurable area. The clitoris is, hence again, my necklace. And again, the clitoris is the penis is the clitoris. They are the same structure. So the vagina, we don't have like a perfect analogy for men, but my closest is, it would be like the rectum. So stimulating the prostate for some men might feel good. Stimulating inside the vagina for some women might feel good. That's like, the G zone. But again, the most pleasurable area is the clitoris for a woman. So most women aren't going to say like, well, because my vagina feels lax now, I'm not having sexual pleasure. That's generally not been my experience with women. However, body image is really important for women, right? Facelifts, breast lifts, all sorts of things, right, that women feel self-conscious about when they feel like their vagina is more open than it used to be. That sometimes can be a bothersome feeling, right? And I validate all feelings. And if that's something that bothers them, that's also something that I offer as far as a surgical intervention, especially if they have air trapping, especially if they feel like the introitus is too open for them. Yes. But I'd love to hear Heather's comments as well.
Yeah, no, definitely. So like you mentioned, everybody thinking that they have a loose pelvic floor. It is definitely your hammock to everything, all of your female organs. And so it's very important that you maintain the integrity of that hammock. But the scariest thing I think we ever did in media was go Kegels, 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 Kegels. So
100%.
and scary. Yeah, because that's not where you should go. You should go to your pelvic floor physical therapist. You should get your musculature assessed. And then, for us, I think I might have it here, is like a pelvic wand. And this would be like a pelvic wand. This is our particular pelvic wand. It's called Easy Magic TheraWand. And so this specifically, this is a longer one that is used if you have to reach around or other things like that. But essentially to help you release those hypertonic pelvic floor muscles, it's really important that you learn the musculature, you understand where you are tense. There are some that can be accessed vaginally. There are some that can be accessed externally. There are some that can be accessed anally. So it just depends. And that's why it's so important for you to go to your pelvic floor therapist and understand your own musculature. And then some of the best things that I always recommend in addition when you do start doing exercises might not necessarily be to go to Kegels. So sometimes some of the best things, especially when you're in a chronic pain state, is utilizing more yogic exercises, because you can use very calming yogic exercises, and you always think of one part of your body is always engaged and one part of your body is always relaxed. And this is what you want to do. You want to create almost like an orgasm. You tense up and then you release. You tense up and then you release. This is what you want to see happen with your pelvic floor. But first, you might need to release that hypertonic state before you start to do those exercises, because all you're going to do is make it worse.
Absolutely.
Yeah, and I would say one more, just as deep diaphragmatic breathing, because again,
Yes.
we have this respiratory diaphragm, right, that when it pulls down brings air into our lungs, and then we have the pelvic floor diaphragm. And when you're breathing, when you do really deep breaths, it forces both diaphragms to stretch a little bit. And again, to Heather's point, really trying to relax. So, I worked a long time at Walter Reed. I saw a lot of type A pentagon females, right? And they would come in and they were just so tight everywhere, right? And their pelvic floors were so tight because they carry all of their stress in their pelvic floor. Like some people carry it in their neck, some people in the back, some people in the pelvic floor, and trying to get them to really breathe correctly to relax their pelvic floor. Because again, we see a lot of tightness and pain syndromes, which is totally different than what I talked about before, which is generally women that have a loose, or more widened introitus. Generally, those aren't the pain patients, generally speaking. They're kind of two separate entities.
Interesting. Okay, I love this. I know I had to learn that from my own pelvic floor a physiotherapist years ago, was that the diaphragm, the breathing, and the pelvic floor itself are so deeply connected. And I love that that's a thing we can all do. It doesn't cost us anything to do. We can do it anywhere, anytime. And I just want to point out too that there is marketing that says if we do 10,000 Kegels by sitting on a machine for 20 minutes, then all of our problems will be solved. And I just want to just bring some light to that and say, maybe not. I also wanted to mention about what you were saying about the Pentagon females. I think that Gen X and the millennials right shortly behind us are holding up the world with our pelvic floors. And I think acknowledging that is
Mm-hmm.
also a really important thing. But that's just me bringing the weird thing into this.
So it's good to bring in weird stuff. It's fun and enlightening.
To keep it a little bit a little less clinical. Okay, but let's go right back to the clinical thing. Okay, what you said was, Dr. Vaccaro, when you were talking about endometriosis outside the bladder, now we have pain coming potentially from the bladder itself, but then you have the sensory nerves that go to the spine, and then we've got the spine up to the brain, etc. It just sort of confirms for me that this is a multidisciplinary approach, taking care of women, women's health, certainly at perimenopause and menopause, which is more than half of our lifetime. And isn't it just infuriating that we're just at this point now where we're starting to really understand how complex this is?
Mm-hmm. I totally agree with you. And again, I think the area of hormones to the genitals, specifically androgens, we are just scratching the surface. We haven't even really peeled back the layers. And I just want to highlight again to reframe it. There are so many androgen blockers women are exposed to throughout their lifetime that can really harm the genitals, specifically that vulvar vestibule, that can trigger these urgency like feelings of, again, because remember the vulvar vestibule is urinary type tissue. So just to quickly run through so women understand what androgen blockers do, the most commonly prescribed is the oral birth control pill. The reason oral birth control pills work so well for acne as well as to prevent pregnancy is because they are androgen blockers. So when you take an oral medication, specifically oral birth control pills, the liver has to it sees so much hormone because again, it's a crazy high amount of hormone that synthetic estrogens are. The liver pumps out a protein that binds up extra hormones because it's like, oh my God, there's too much hormone out here. And it also binds up testosterone or androgens, right? So now we have this binding globulin out there binding up all the testosterone. So now it can't work on the genitals. So that's how birth control pills lower androgens. Another really common one is spironolactone, which often is used for acne. And again, these are super common medications that are prescribed to women. And I don't think what we've done really, Fiona, very well is look at those patients and see how many patients are getting the urgency or this IC or vestibulodynia picture, right? Because this can happen throughout a woman's reproductive cycle. It doesn't just happen at perimenopause or menopause. These androgen blockers are happening throughout a woman's lifespan. But then when they get to perimenopause, menopause, and they've had these androgen blockers and then they lose their estrogen, oh my God, right? Now we have no hormones that support the vulvar vestibule, which has really dense amount of estrogen and androgen receptors. And now it's like adding fuel to the fire, right? It's just aggravating a condition that already might have been bad and now it's making it worse. So we see these, again, androgen, and we don't have we don't have any product right now on the market that specifically targets that. There is Interosa, which is FDA approved. It's a DHEA style suppository that does turn into estrogen and androgen at the cell level. So there is one product available, but we need more products. We need more products other than compounding pharmacies, which what we're using right now to give back androgens, meaning testosterone and estrogens, to the tissue in combination. But we need more. Mm-hmm. And again, we've just barely scratched the surface. We haven't even really fully described these phenotypes, in my opinion, very, very well, so that it's clear for clinicians and for patients why this might be happening. Certainly there's other causes, right? This is a hormonal cause. There can be immune modulation. There's a theory that it's an infectious etiology, right? There's all these other, and then we haven't even, really explored the, mast cell activation syndrome that also can be another sort of a predisposing factor for these patients, right? Too much histamine response. There's all these buckets that I don't think anyone's really, we don't have a good, clear tool for clinicians of this is where you start and this is where you go, right? It's not clear at this point.
So complex. Holy cow, so complex.
Yeah.
Heather, go ahead.
Yeah, I was just going to jump in here because I can mention a few things that we've done in our research just a little bit towards some of this and that we're actually still concurrently working on. And one of them is, so as she mentioned, kind of those therapies, we're kind of the non-traditional naturopathic more therapies here at Desert Harvest, the company I'm the CEO of. And one of the products that we're undergoing FDA drug trials for right now, we're currently in double-blind placebo-controlled studies at Wake Forest University in North Carolina, is our SSAV, which in clinical trials that we've previously done over 33 years, we've had an 87.5% response rate of some or complete relief of all symptoms. So when I talked about those hallmarks, that frequency, that burning, that pain, and the nocturia, that those were the hallmark symptoms that we were looking at and looking to address. And so we have followed that up over the years, increasing our research and our evidence. We did this was of course not blinded research, but we had the Interstitial Cystitis community, the Interstitial Cystitis Association, actually the only nonprofit, reach out to their entire community and literally have them all fill out questionnaires. We had 660 respondents and 92% within that study. And so
Amazing.
This is what has led us through all of our work. And then we've added on companion stuff. So she mentioned like that calcium, the calcium glycerophosphate. We have two different kinds of calcium. We have a calcium glycerophosphate that specifically in clinical research neutralizes acid up to 95%, related specifically to the foods. But when we're having other issues, sometimes that calcium glycerophosphate doesn't work for everybody. So we have a calcium carbonate with a vitamin D3 that seems to be more effective for others because it more neutralizes acidity within the body. And then at the same time, you mentioned the mast cell activation component. So this is not for everybody. We call it the allergic bladder, and not everybody has this. And of course, during high allergen times like we're in right now, we see an increase of people saying I'm flaring and I'm having breakthrough flares, other things like that. And so we have another thing so typically the typical prescribed would be a hydroxyzine. It's an over-the-counter antihistamine, has a huge, on the other side of it, maybe not waking up very well in the morning. And
Quite sedating.
Yes, and so we have also what's called quercetin, which is from the Sapora japonica plant, and in our clinical research, we can show that kind of add the flavonoids in there naturally help to calm that aspect. So we have created over the years, and then when we go to that, I know you mentioned the androgen and kind of synthesizing and figuring that out. It's actually one of the things that we just studied, and we're studying further because we just released the world's first human lactoferrin, not from a cow, it is the first human bioidentical. We start with human lactoferrin, and then we're able to replicate it. We created with this amazing team in New York, the world's first. And so this is what this is going to do, especially for menopausal women, is this is an iron binding glycoprotein. And so what that's going to do is help maintain iron homeostasis in the body, whether you're too low or too high, which a lot of menopausal women are, heading towards hemochromatosis. And so it kind of creates that balance. But at the same time, we're watching how it is interacting. And at the same time, when we start to create that iron homeostasis, we're watching it also create that hormonal homeostasis as well. And so it's not necessarily going to supplement or replace what HRT does, but it can help balance what is already naturally there and what your body is producing or supplementing in that case, and help kind of create that balance. And at the same time is going to synthesize collagen better in the joints than supplementing collagen. It is also going to help optimize gut function better than pre or probiotics, all problems we know as menopausal women. And we feel like this has become our catch-all product because we keep doing more research. And, this is the stuff that when bodybuilders are going out on the black market trying to buy breast milk, it's because they want that lactoferrin in their for their
Okay.
workouts.
Interesting.
And yeah, so not
Yeah,
only do I take this, but my husband takes this, my boys take this, like, and just because
that's
of the
amazing.
beneficial immune system properties as well.
And where can people listening to the show find that product you're talking about?
Oh, on our website, it's desertharvest.com.
Okay, fantastic. All right, thank you for that. I had no idea. I'm very interested in this product you're just talking about. I'm going to go take a look myself for sure after this. Um, Christine, I want to come back to something that you said earlier about, actually, I think I'm going to quote you. Clitoris and penis, penis and
Mhm.
clitoris, same thing. Can
Mhm.
you tell us more, please?
Yes. Oh, this is one of my favorite things to talk about. So we're going to break it down just piece by piece. So each of our structures has a hood covering, right? A glans covering. So in men, that's the foreskin, and in women, that's a hood or prepuce. So both have a glans and a glans covering. We both have two long legs that stretch back. They're called crura. Okay. And we both have a central portion, which is the bulbs. And the one of the big differences, yep, there we
Yeah.
go. Heather's
So the
describing
pink,
it beautifully and showing the whole clitoral anatomy there.
the pink
Yeah.
is
So,
the legs of the cruise, you said.
yep, the legs that go out to the side, those are the crura, or what we call
Okay.
the legs, and the central portion there is the bulbs. And then you have the urethra, which for women goes kind of underneath the clitoral structure. For men, it goes through the penile shaft. So a little bit of a difference of where the urethra exits,
Mhm.
and then of course the clitoris has a little bit more nerve density, about 10,000 nerve fibers, and males have about 4,000. So I always say, even though there is a size difference, tiny is very mighty, right? Because we have 10,000 versus 4,000,
Thank you,
uh,
Heather.
very densely packed, but really they are the same exact. If you cross-sectional anatomy and you look at the clitoral glands, the nerves, the fascia, the erectile tissues, they look almost exactly the same as a penis. And I think in our culture we have done a bad job in popular media describing what a woman's sexual pleasure is, right? And we've equated penis and vagina, which is not the equivalent. Okay. That is just where men like to put the penis, but that does not mean that's what it is for a woman. That's not where most sexual pleasure happens. Not that some women don't find pleasure in that. A lot of women do, but the clitoris is the penis is the clitoris. I can't say it anymore. Simplified. They're the
Okay.
same structure.
I love it. I love it. Okay, so let's talk a little bit about this whole pleasure anatomy for women in terms of the practicality of it. As you've just said, most women will not have the pleasure experience from the vaginal stimulation, but from the clitoris. So please,
Right.
Christine, give us permission. Give us
Yes.
all the permission.
Please explore. There is a wonderful website, omgyes.com, that shows really tasteful videos on how different women find pleasure, really tastefully done. Women are all so different. And I would say to women, don't expect a partner to figure out how you like pleasure. That's like having someone pick out your favorite meal for you. Like, you need to experience your favorite meal. You need to experience how you experience pleasure. So don't expect a man or a partner to figure that out for you. So please, I give you permission to explore yourself and figure out what works for you. So then you can tell a partner what works for you, right?
Oh, love it.
Um, so for most women, that anterior or the G zone, there's lots of erogenous zones in the body, but the G zone really is just a way to stimulate the internal portions of the clitoris, right? So the anterior distal wall of the vagina, which is just right inside the vagina, you press on the urethra and the internal portions of the clitoris. This is the exact sort of same area as where prostatic stimulation would be for men, which for a lot of men, they enjoy that, right? So it is an erogenous zone, but it's not the same as the tip of the penis, which is not the same as the tip of the clitoris, which is the glans. Those are the most densely innervated pleasure zones for men and women, the glans, which
Right.
is the tip.
Okay. Yes. Fantastic. Heather, do you want to add anything?
Yeah. The only thing I can add to that amazing description is just to say that definitely play with yourself. Like I,
Yes. Yes.
I will always recommend there's a tantric practice, and I recommend this to anybody that I'm speaking to, and that is kind of go into your bedroom wherever you feel comfortable. Set your mood, hit the five senses, get the music, the feeling, your sheets, silk, it's light a candle, whatever makes sense for you, and then set a timer on your phone for 20 minutes and start to touch yourself. You don't have to go straight there. You don't have to go straight to the clitoris, straight to the bang and everything, but instead begin to touch yourself, and not just in your vulvar area, but everywhere. Understand what about your body feels good to you, what doesn't. When you get down to your, vulvar anatomy, grab the mons pubis. You can literally just grab it and hold on to it. See how that feels to you. Touch your inner thighs, and then you could begin to touch like your clitoris and begin to bring yourself up, but then bring yourself back down. You don't want to until that 20 minutes ends. And this tantric practice will also be very orgasmic at the end if you so choose. But at the same time, it becomes an area of self-exploration and really understanding your body for those 20 minutes. Give yourself those 20 minutes to understand what feels good about your body and what doesn't. And then that lets you make informed choices when you're there with others. And when that 20-minute timer goes off and you want to grab your vibrator, grab your bullet and climax. And I'll tell you, it will be an orgasmic experience. Just remember, when you start to feel yourself come up, you need to bring yourself back down. And that goes into that diaphragmatic breathing that Dr. Vaccaro mentioned earlier, really breathe that out. And that is calming through your vagus nerve. That's calming that sensory experience and bringing you back down so that then you can begin to explore and touch and then bring yourself like a wave. It's called ocean breathing. So in Tantra, so literally bringing yourself up, bringing yourself down, bringing yourself up, bringing yourself down for 20 minutes. And then at the very end, you can climax if you'd like.
Amazing. That is a fantastic practice. I love that. And permission given in two different ways, on two different levels. And I love that. And one of the things I like to share with my patients in particular is to talk about the deliberate pursuit of pleasure. And we have to, like, when we've got all the hormones of reproduction going, we naturally find ourselves doing that. But when that starts to decline at perimenopause, and when the hormones are gone at menopause, potentially before HRT, or it's just different with HRT even, making it a deliberate practice where you are setting aside time, and the only thing that you are allowing in that time is just the exploration of the pleasure experience, I think is really, really important. And I also think this is an important part of what happens with libido too, is we wait to feel horny. But listen, that really stops for a lot of women at midlife. If you wait to feel like you did when you were 22 with your 22-year-old vagina, it doesn't come, is all I'm saying.
Well said. Well said. But we do have tools if you ever want to feel your 20-year-old self again. So I am also throwing out there that there are two FDA approved medications for libido. And there's also, of course, off-label testosterone and a few other off-label medications that we can, if women so choose to feel those thoughts again, that we do have tools for those.
And do you feel that do you find that they're working well? I don't have much experience with them.
Yes. But my go-to generally is female-based testosterone. That's my general go-to because it's more of a natural way to do that. But the two medications, the pill, flibanserin or Addy, and then the shot, bremelanotide, Vyleesi, are both really great therapies as well.
Okay, so, fantastic. It's good to know. I don't know if the Canadian physicians are doing that so much because I don't hear my patients talk about that one, but I'm always the one to say, hey, by the way, did you get the testosterone cream? Okay, let me tell you how to apply it to the vulva for a little boost. And it sure does work really well that way.
Yeah, amazing.
Yeah. Okay, well, thank you for this conversation. I have to say, I have learned so much, and I feel like if we were sitting at a table, we'd have to have food delivered because I would just keep asking you questions, you guys. Anyways, Heather Florio, please tell the listeners where they can find out more about you and your products again, please.
Yeah, definitely. So we are on Instagram. My Instagram is just at HM Florio or at Desert Harvest Aloe Vera. And then the website again is desertharvest.com. Please, yeah, we're always here to answer questions and help you guide you to the right clinicians or wherever you need to be.
Yes, thank you. Thank you for the work that you've done on behalf of women's pelvic health. I'm so grateful. Thank you. Dr. Christine Vaccaro, please tell people please tell us where people can find you.
Yes, I'm on Instagram my handle is at Dr. Dr. Christine Vaccaro, and then also at the offices of Rachel Rubin. So you can email or go onto the website, info@rachelrubinmd.com is how to get a hold of us and find me. I live in the Bethesda area. That's where my practice is.
Fantastic.
Maryland.
Please keep doing the things. Please keep sharing the skills that you learned with your training that was so different from how other gynecologists are getting the training, and just spread the word. But I have a final question I ask all my guests on the show, which I'd like to ask both of you first. Heather, I'd like you to go first if you don't mind. So the question goes like this. Knowing what you know now, what would you tell your younger self?
Play with yourself.
What a great bit of advice. Christine, how about you?
Oh, there's so many things I would tell myself. Probably most of it is just has to do honestly with confidence. I think when women are younger, they don't feel maybe as confident as I do now, right? There's this superpower that comes with perimenopause and menopause, which is you don't give the F's anymore, and you also just feel like you can stand in your power, so to speak. So I think it would just be more confident. You are worthy, and you have a lot of knowledge, and you have a lot of things to share with the world, and don't be afraid to speak up.
Thank you. I love that. Great advice. Ladies, thank you for joining me today on the show.
My pleasure.
Thank you.
The information and other content provided in this show, or in any linked materials, is not intended and should not be construed as medical advice, nor is the information a substitute for professional medical expertise or treatment. We are doctors, but we aren't your doctor. Seek your doctor's opinion. If you or any other person has a medical concern, you should consult with your healthcare provider or seek other professional medical treatment. Never disregard professional medical advice or delay in seeking it because of something that you have heard in this podcast or in any linked materials. If you think you may have a medical emergency, call your doctor or emergency services immediately. The opinions and views expressed on this page and in this show have no relation to those of any academic, hospital, health practice, or other institution. Thank you.